Yes, my name is Bill Skeen, and I'm the Executive Director of a group called Physicians for a National Health Program. I'm in charge of our California chapter, and I'm delighted to be here at Enloe and also with you here tonight in Chico. I did find this vintage photo of your hospital, which I decided to include in my slides. Physicians for a National Health Program is a group of around 20,000 physicians nationwide who believe that we should have some kind of national health program as our solution to our healthcare problems that we've been talking about here tonight. So I don't know if it's a blessing or a curse to go last after our last two presenters. I do find that I have some of the same material. However, I think I'm going to present it with a different, somewhat different spin or a different point of view. And for things that have been covered fairly quickly before, I'll go through them fairly quickly. But tonight I also do have some ideas about how we can move forward to help resolve some of the issues that were brought up that still exist in our healthcare system that were not completely resolved with the last round of reform with the Affordable Care Act. Am I loud enough? Can you guys hear me okay there? Okay, great. So the Affordable Care Act is turning 5. And there we go. So I'm sure most of you know that the United States has a healthcare system that actually has two pieces to it, which are really quite different. One is our program for our seniors who are 65 and over. This is publicly funded insurance, and we refer to that as Medicare, which has been around since 1965. For people who are not yet 65, we of course have our private insurance system, where people purchase insurance through private companies and often through their employer. So the Affordable Care Act was born 5 years ago on March 23rd, 2010. That's when the first day it was enacted. It was originally called the Patient Protection and Affordable Care Act, but more recently they simply referred to it as the ACA or the Affordable Care Act, or sometimes Obamacare. Previous speakers have covered a lot of the stuff that happened when the Affordable Care Act was enacted, a lot of the major provisions. I did want to just briefly review 4 of them that I think are really salient for you here in the room today. One is the Medicaid expansion. The other would be the increased regulation on our insurance companies, the institution of an individual mandate, and the establishment of the health benefits exchange that we've heard about before. So I think Amber covered the Medicaid expansion pretty well. A lot of people think that Medicaid, which in California, of course, we call Medi-Cal, is our insurance program for the poor. One thing I'd like to point out is that in reality, before the Affordable Care Act, it only covered certain categories of poor people, mainly women and children. And with the Affordable Care Act, one of the most significant changes is that it now truly covers all of the poor, and by that definition, that would be up to people whose incomes are up to 138% of the federal poverty level. Amber mentioned that there was a Supreme Court decision a couple of years ago, which made made expanding Medicaid optional for the states, and 22 states decided not to participate at the moment. 6 states are discussing how they might eventually join that. Okay, the other thing, next major thing that the Affordable Care Act did was to increase regulation on our insurance companies. Again, prior speakers have talked a lot about that, but perhaps we can talk a little bit more about some of the reasons why that was necessary. Like all corporations, private insurance companies exist to make a profit. Basically, we all give them our premiums up front, and to the extent that they don't have to spend that money and they get to keep it, they make a profit. This creates, in some ways, a perverse incentive that if they're able to deny care, they make more profit for their shareholders. And I can tell you over the decades, private insurance companies have become experts at finding ways to deny people care. Dr. Thorp mentioned a few of them that were fixed by the Affordable Care Act. One, of course, was lifetime caps. So the only people that were running into their lifetime cap were people who were really sick and needed some really expensive treatment. So basically, when you were getting your radiation or getting your heart surgery and you started to get near your cap, at that point you might be cut loose by an insurance company and find yourself without coverage at all. So a fairly cruel decision in terms of saving money for the insurance companies. Other things were mentioned before, rescission. Rescission was basically perhaps you need some expensive treatment. Your insurance company decides to go look up your initial application. They discover that you forgot to mention your acne. They accuse you of fraud. They cancel your policy on the spot, and they don't have to pay for your expensive treatment. There were many other kinds of these practices by the insurance companies, and some of them still exist, but the Affordable Care Act did get rid of them. A very nice improvement is the getting rid of the pre-existing condition clause. So for instance, if you were signing up with a new health insurance company and you had asthma, they would insure you and cover all of your medical costs except your asthma for the first 1 or 2 years. And then finally, if you were still on the insurance and your asthma hadn't taken you down, they would start to cover your asthma costs as well. One other benefit, of course, that we're all familiar with from the Affordable Care Act is that young people were allowed to stay on their parents' policies until they were 26, which was another way of expanding coverage. Okay, we talked about the individual mandate. What the individual mandate does really is create one large risk pool. So if everyone has to contribute to the system, it makes it less expensive for all the rest of us. And also, it's just a good idea for everyone to have health insurance. There's some talk sometimes about, well, maybe young people, they're healthy, why should they be forced to buy a policy? And that's basically because unless you have a crystal ball, you're never sure when the day might come that you accidentally look the wrong way and step out in front of that bus. Everyone is at risk for any kind of health problem, and so it's really best if everyone has insurance. Amber talked about the penalties. Okay, the health benefits exchanges were set up in 14 states. California, of course, was the first. And sometimes there's confusion among people I talk to about Obamacare, insurance, or the Affordable Care Act insurance. And it's a slight little adjustment, but the Affordable Care Act is not an insurance plan. It is, it's a set of changes to our healthcare system. And the marketplace itself is a place where you go. It's an online marketplace. You go and you review the plans that are available, and you decide which one might work best for you. This is Covered California. When you go to the website, this is what you find. This is your departure point where you can start an application. Okay, so our prior speakers did talk about the health benefits exchanges, but I did want to mention more specifically that they're organized in 4 metal tiers. So there's bronze, silver, gold, and platinum. The differences between these plans are in the out-of-pocket expenses. So if you get a bronze plan, it's going to cover 60% of your healthcare costs. The next tier covers 70, the next tier covers 80, and then at the platinum plan is going to cover 90% of your expenses. So the premiums are much higher for if you select a platinum plan. However, the other out-of-pocket expenses are lower, so it's kind of a trade-off. Overall out-of-pocket expenses for all of these plans are capped each year. And the other difference that I would mention about the metal tier plan. So when you go shopping on the marketplace, if you live in Santa Barbara like I do, or if you live up here in Chico, you're not going to see the same plans available to you. That's because most health plans offer insurance in a network that is only located in a closed geographic network. So even, for instance, if you live in Los Angeles and you want to get healthcare with your plan in San Francisco, that would not be inside your network. So the networks are not only closed, or limited, I should say, in terms of the number of providers that you can access, they're also limited in terms of the geographic region where you can seek access. And oftentimes, if you want to find care outside of a network, it's going to be either not covered, in which case you're on your own to pay for it, or with substantial out-of-pocket expenses. Subsidies. So we did mention subsidies. I would just say that of everyone that signed up nationwide to get health insurance through the various exchanges, 87% of people did indeed receive subsidies. Okay, so hopefully that will kind of end the part where I overlap with my prior speakers, and we'll talk go into kind of a different direction here in talking about what are some of the things that we could do to improve our healthcare system. So with the Affordable Care Act, the people who were trying to create change recognized that our healthcare system needed change, and all of those involved in trying to figure out what that change should be, I'm sure had a set of goals in mind. Whether you're government, whether you're legislator, whether you're consumers, whether you're a health policy expert or a healthcare economist, I think we probably all have shared goals. So I think the goals of reform might be summarized as saying that we would all like to have comprehensive, high quality, and I do this so often, high quality, comprehensive, affordable healthcare for all. So that one sentence rolls together four things that I think can be considered a goal for healthcare reform. So in keeping that in mind, we can kind of move ahead and take a look at what was achieved with the reforms of the Affordable Care Act. One of them that we have to mention right off the top is that the Affordable Care Act has not yet succeeded in insuring everyone. And in fact, there are 30 million people that are going to be left out. These are people without insurance. And most of this is due to the fact that the states that decided not to offer health care coverage to their poor is leaving their poor uninsured. So those make up the bulk of these 30 million people. My organization, the Physicians for National Health Program, did a study out of Harvard some years ago that showed that that this probably results in about 3,000 people annually dying simply because they can't access care. So there is some significance to having 30 million people left that we haven't dealt with yet. In California, that number comes down to 3 to 4 million Californians that after the Affordable Care Act is fully implemented will still not have health care coverage. Of that, approximately half of those folks in California are undocumented. And I would mention that efforts are already underway here in California to offer, to expand coverage to the undocumented here in California. In fact, just this week, Senator Lara's bill, there's a bill by Senator Lara, it's called SB4. It would allow the undocumented to be eligible for Medi-Cal, and also if they were able to afford it, they could purchase a private policy on Covered California, although they would not receive any kind of subsidies. I can tell you that yesterday, that bill was heard in Senate Health Committee and passed unanimously. Okay, and prior speakers, again, didn't mention that coverage is not the same as access, and access is not the same as care. So in California, that number is 43% of physicians that don't accept Medi-Cal, primarily due to the fact that the reimbursement rates are fairly dismal. Beyond that, if you have no insurance and then you are able to access Medi-Cal, most people consider that a wonderful thing. However, Medi-Cal itself is a limited program, and there are actually limits for some people on how many times they can go see the doctor. So again, you can't really predict your healthcare and your healthcare needs, but to put an arbitrary limit for financial reasons on access to care is then putting a barrier on care to people who are now in our Medi-Cal program. And then we talked extensively about the limited networks that some private health insurance companies have created for the plans that are offered on the exchange. I would mention that for the Medi-Cal number, 1 out of 3, since the Affordable Care Act, 1 out of 3 Californians now get their health insurance through Medi-Cal or Medicaid. If you wanted to add in Medicare, TRICARE, which is from the military, perhaps the VA, S-CHIP, and other forms of public insurance, I don't know the number exactly, but I'm guessing that somewhere around 50% of people in California probably have some sort of government health care provided to them. So I think that moves the debate well beyond does government have a role in healthcare? I think it's pretty clear that they do. So I think perhaps the debate could move in the direction of so since government's providing all this healthcare, how do we do it in a way that's better all the way around? And by better, I mean, how can government provide health insurance that it's better for patients with better health outcomes, and also better from the financial sense? How can we do this in a more cost-effective manner? Okay, so since the Affordable Care Act, I wanted to kind of go through some challenges that remain. Our prior speakers, again, did do this, but I'm going to do it with a different perspective here. So the Affordable Care Act did not really protect people living in America from financial harm. So, and that's because of the possibility of very high out-of-pocket expenses. Out-of-pocket expenses include premiums, copays, co-insurance, and deductibles. And even though they are limited each year by the Affordable Care Act, it's still possible in this country to go bankrupt even though you have insurance. This happened to one of my neighbors down the street, as a matter of fact, who had some very expensive treatment for breast cancer, and her insurance company stepped in and picked up the majority of her bill. But the copays and the out-of-pocket expenses that she was left with were so overwhelming to her that she then had to go declare bankruptcy. Unfortunately, the United States has the unique distinction of being the only country where that's possible, of the developed nations. And then there's the question of healthcare quality. A hallmark of the United States system is, unfortunately, inequality. For instance, if you live in Beverly Hills, your life expectancy is 86, and if you live in South Central LA, your life expectancy is only 73. So obviously, one can't simply move across town to improve your health. There are many other factors that are at play here, but these kinds of disparities based on where you live reflect complicated factors, but access to healthcare is one of them. Clearly, people in Beverly Hills have much better access to healthcare. A recent study came out a few months ago showing in Los Angeles that the rate of diabetic amputation, losing your leg or some other body part, totally depends on where you live within Los Angeles County. And it should not be that way. So I wanted to spend a few minutes on this idea of profit versus patient care. I think most of us would, we mentioned before how private health insurance companies are corporations, and as any corporation is supposed to do, they're supposed to make a profit. But we have to look at whether that's really a good thing within our healthcare system. I think most of us agree that making money by denying care and letting patients suffer the consequences is not what we would consider a family value. I wanted to mention a recent example. This is just an example I picked because it's been in the news lately. There's a company you may have heard about called Prime Healthcare. They recently offered to buy 4 Catholic hospitals in the state of California that were failing financially. And so Prime has a business model. It steps in, makes the necessary changes from a business perspective, and has in the past succeeded in keeping these hospitals viable. However, when you look a little closer about how they accomplished that, they often do it by cutting out services in the community that the hospital offers to the community that are not profitable, and in particular, oftentimes indigent care is no longer provided. So the hospital gets saved for the community, but does the hospital still serve the community? So I'd just like to make the point there that shareholder need and what patients need is not really always the same thing. Okay, so we have a big birthday party coming up. This is going to happen on July 30th, later this year in 2015. Our Medicare program, originally passed in 1965, will turn 50. So we just celebrated the Affordable Care Act's 5th birthday, and now we're about to celebrate Medicare's 50th. So if you remember the slide I showed at the beginning with Janus, the 2-headed Roman god there, we have 2 halves in our healthcare system here in the United States. So our president and Congress, when they tackled healthcare reform starting back around 2009, they decided to use as a platform for the Affordable Care Act the left side of the screen, which was our private health insurance system. There was an option. They could actually have started on the other side of the screen, on the right side, and as a platform for reform, they could have started with the Medicare program. They could have improved it, expanded it to cover everyone from birth to death, as Medicare was actually always intended to be. All the way back to Truman, President Truman discussed trying to implement a program that would provide publicly funded health care for the middle class. That idea has been around a really long time. And when it came to 1965, that was the original intent. However, the politics of the day came up with a compromise, and that compromise was we would give publicly funded health insurance to our seniors and to the poor, and later on the disabled were added into that. But for some reason we left an entirely different system in place for people who are less than 65. Okay, so if we did improve Medicare, and expand it and give it to everyone, what would the improvements be for patients? There are many, but I just selected a few here. Pardon me. Simplicity would really be a major advantage. Basically, a Medicare for everybody plan. There'd just be one plan. And the reason there'd only be one plan is because it would cover everything. It would cover all medically necessary treatment. It would eliminate the need to go to the Covered California website and shop for plans that give you something but not everything. The Medicare plan would give you everything and simplify the entire system. Not only would you get a plan that covers all medically necessary treatment, but you could use that anywhere. You could see any doctor. You could see a doctor in Chico. You could, as my parents did with their Medicare card, they could go to different parts of the state or even outside the state and get the same coverage paid for with their Medicare insurance. So Medicare is literally good everywhere in the United States, and there's absolutely no tie to employment. Okay, what would improvements be for doctors? There is a long laundry list of how difficult it is to practice today. I hear that from my colleagues all the time. And under an improved Medicare for all kind of system, I think many doctors would benefit tremendously. For one thing, all of the patients that they see would be insured. There would be no unreimbursed care. Everybody would come in with an insurance card. Everybody that came in with that insurance card would have one plan, so there wouldn't be a need to have a lot of administrative support on the phone, calling up different companies and saying, do you cover this treatment? Is this drug on your formulary? 1,500 different insurance companies that have different forms, different plans, and different people advising what you can treat and what you can prescribe and what treatment you can prescribe as a physician looking over your shoulder. So tremendous simplification in terms of billing and administration and treatment decisions under an improved Medicare for all kind of plan. That leaves patients or physicians with more time for patients, and that's definitely a good thing. Okay, just briefly, some improvements for hospitals. Hospitals would basically provide the services that meet the community need, because under a Medicare for all kind of program, there would be a community planning process. So sometimes in today's world, a hospital will make itself attractive by perhaps adding something like a new MRI machine, and you might find yourself in a place where there are many MRI machines that hospitals have purchased in order to make themselves more competitive and more attractive. But the need for those MRI machines is not necessarily determined by the community need and utilization. Hospitals would be funded by the Medicare for all kind of system. It would be operated on global budgets. And for those of you who read this, the Time magazine article by Stephen Brill about the charge master, which was eye-opening for many of us, it's the list of charges for individual services and items that a hospital keeps. And the point about it being that the charge master's prices that were listed were not necessarily tied to any kind of pricing reality. Presumably that kind of thing would no longer be around. So I'm often asked, how would we pay for such a system that covers everybody and provides all medically necessary care? So I do have an example that comes from Gerald Freeman, who is an economist at the University of Massachusetts in Amherst. Professor Friedman proposes that with these 5 taxes, we could fund a Medicare for all kind of system. The first one is a 0.5% tax on stock trades, sometimes referred to as a token tax. And then you have also a high income surtax on people who are earning in the top 5%, and some additional payroll taxes on top of the current payroll taxes that we all pay for Medicare currently. So yes, we would have to pay more taxes in order to fund a Medicare for all kind of system and provide health insurance for people from birth to death. On the other hand, we don't have to pay premiums anymore to private health insurance companies, and we would have to pay no or at least greatly reduced out-of-pocket expenses. So I kind of use myself as an example here. I currently pay $1,100 a month for my health insurance premium. I have a Kaiser Platinum plan. My spouse pays $850 a month. Actually, for the same plan, I get mine through work, and he gets his through the exchange. So he's saving a few $100 there by having purchased it through the healthcare exchange Covered California. Then we have some combined co-pays every month, some co-insurance every month, and I totaled that up and I found out that in our two-person family, we're spending $27,480 on two private insurance companies from our healthcare every single year. So, you know, if I didn't have to pay this, how much taxes would I be willing to pay? And I think that answer is just clearly less. I'd be delighted if I could pay less money than that in taxes, and especially if I could pay significantly less. I guess that remains to be seen. So I'm going to stop there, but I would say that I'm not exactly sure the direction that healthcare reform will take from now on, but I would say that there are those of us who still dare to dream. Thank you very much.